It is my great pleasure to introduce Dr. Lisa Diller, MD, as our speaker for today. Dr. Diller is a pediatric oncologist at the Dana-Farber Cancer Institute and Boston Children's Hospital. She is professor of pediatrics at Harvard Medical School and vice chair of the Department of Pediatric Oncology at the Dana-Farber Cancer Institute. Her clinical and research interests are in cancer predisposition and cancer survivorship. She's also recognized for her work in developing therapies for high-risk neuroblastoma. Dr. Diller has a strong relationship with ALSF, including being an integral part of the team that was awarded our newest Crazy 8 Award, focused on screening approaches for cancer predisposition. So on behalf of ALSF, I wanted to thank Dr. Diller for her time today, and we'll pass over to her for a presentation titled Newborn Screening for Cancer Risk, Has the Time Finally Come? And as a quick programming note, we will have a Q&A session after the presentation, and you may ask questions to Dr. Diller using the chat feature. So with that, I'll pass it over to you, Dr. Diller. Thank you again for joining us.
Thank you for having me. I'm thrilled to be here. I looked at who's given this seminar in the past and feel honored to be in such company. I'll be talking today about newborn screening for cancer risk, as mentioned. And I thought I would tell you a little bit about how I, a pediatric oncologist, end up talking about newborn screening. Give you some information about newborn screening, particularly in the United States, and then talk about our work in population-based newborn screening for cancer risk. I'm going to talk about myself a little bit, in part because if there are junior faculty or trainees in the audience, sometimes a career takes a long and winding road, and I think it sort of gives you a sense of where cancer predisposition work has gone over the past few decades. My learning objectives including, I want you to ponder the question, should genomic newborn screening include testing for cancer predisposition, and to understand the pitfalls and risks of population-based genetic testing for childhood cancer risk. So how did I get here? In 1986, I was a relatively new grad from medical school doing my residency, and on the New York Times front page below the fold was an article entitled Scientists Find Gene That Blocks the Growth of a Form of Cancer. This was the RB1 gene that was first identified. The quotes from the article include, "This is the first time a gene has been isolated that explains predisposition to cancer in a hereditary way." And Bob Weinberg said, "There will undoubtedly be a whole panoply of cancer predisposing genes," which of course he turns out to be right. I remind you, though, when I was a resident, we were taught, except for retinoblastoma, to tell our families that cancer was probably not genetic. No worries. Then in 1988, I became a first-year fellow at the Dana-Farber studying becoming a pediatric oncologist. And at the same time, around the same time, Dr. Lee and Dr. Fraumeni published their clinical work on family cancer syndrome that became known as Lee-Fraumeni syndrome, a syndrome probably well known to many of you, associated with the early onset of cancer, characteristic childhood cancers, as well as early onset breast cancer, and subsequently identified to be associated with the p53 gene. These are images from two of the patients I saw during that first year, both of whom developed secondary cancers after childhood cancer, one a gastric carcinoma after radiation for Hodgkin's disease, and another a rhabdomyosarcoma after treatment for retinoblastoma and radiation. And this really piqued my interest in survivorship and in cancer risk, and I was somewhat convinced that we would be able to explain the occurrence of secondary cancers if we only understood the genetics better. And for that reason, I went to a lab. We all went to labs in our second and third year. I went to Steve Friend's lab. Steve had been a fellow in our program and had cloned the RB1 gene, participated in that, and then developed at the same time that I was in the lab with David Malkin, who was a postdoc with me, the association between germline p53 mutations in Lee-Fraumeni syndrome and Lee-Fraumeni syndrome, the occurrence of Lee-Fraumeni syndrome. And I was at the next bench when David first sort of looked at his sequencing results that showed that relationship. But I was interested in retinoblastoma and bilateral retinoblastoma, and I actually had this idea about newborn screening that perhaps using biochemical testing, we could figure out a way to test children who had an underlying defect in the RB1 gene or in RB protein, and thought about a variety of functional assays that we might be able to do. But my project in the lab was cloning the RB1 gene in xenopus, and I did not make great friends with the frogs. I didn't really like working in the lab, and so I left the lab and ended up working with Fred Lee, shown on the left here, with Joe Fraumeni, in some of the early work that was done in our field, looking at constitutional or germline mutations in a variety of genes associated with the occurrence of childhood cancer, as well as thinking about how a clinical service might be impacted upon the findings that were coming out in these years. As many of you are well aware, over the decades to follow, it became very clear that there were not only RB1 and P53, but there were a number of genes that predispose children to developing early onset cancers, as described in the seminal paper by Zhang et al., and subsequently confirmed by many other investigators, that somewhere probably upwards of 10 to maybe even 20%, depending upon which genes are included, of children who develop cancer are found to have high or moderate penetrance genes in the germline that account for the development of their cancers. So I went ahead and spent my career really thinking about embryonal tumors, including the RB1 gene and children with retinoblastoma. I'll be talking a lot about this, but I thought I'd start with a case, a family that I take care of. These two children are siblings. The young man on the right was diagnosed at 18 months of age with bilateral local advanced stage retinoblastoma. He was treated with chemotherapy, radiation, and ended up with bilateral enucleations and is obviously blind. Was found to have a germline pathogenic RB1 variant. His sister was diagnosed at birth as being a variant carrier, and she was noted to have multiple tumors throughout the first year of life, but was treated with local measures only and a cryotherapy mostly, and has absolutely perfect vision. And this is just a case in point for why I've always thought and continue to think that early identification of carriers of RB1 pathogenic variants might be an important innovation in pediatric oncology, resulting in improved visual outcomes overall, less need for systemic chemotherapy and their acute and late side effects, less need for radiation and the high risk of secondary cancers associated with that, and perhaps even better survival. But interestingly, the mother, just like I do, asked me, well, why don't you just test every baby for cancer mutations? I mean, if you had tested my son, he would not be blind. And as you can see here, there are multiple diseases for which children are tested using the newborn dried blood spots, but none of them at this point are cancer risk. So, this mother was aware that when her babies or children were born, as many of you parents in the audience are aware, and your children undergo a hearing screen, a newborn screen heel stick, and pulse oximetry testing, all of which are chosen to detect early onset diseases in children. The blood test is blotted onto a Guthrie card or called a dried blood spot. Those are sent to state laboratories. Many of them are stored for future work and research. And then the information that is gleaned from that testing, mostly biochemical testing, is transmitted back to the pediatrician, who then might refer or develop an intervention that can be life-saving. This began with testing for phenylketonuria and with the use of an exact diet that prevents morbidity, the disease associated with the condition associated with phenylketonuria, which is severe cognitive dysfunction and requiring institutionalization in most cases, has disappeared from the population. So it's a very successful population-based health intervention. The goal of newborn screening in the United States, then, is to identify newborns with rare disorders prior to the development of symptoms, whose outcomes can be improved by early initiation of therapy. There's something called the Recommended Uniform Screening Panel, which proposes the disorders to be screened at birth to states. Each state mandates its own panel, and state public health labs perform the dried blood spot analyses. There are 37 conditions recommended by the RUSP. Each state gets to decide which conditions on top of that they want to do. Massachusetts includes 60, Texas 55. The cost per baby is between $100 and $150. Most of the diseases right now are biochemical tests, with DNA testing increasingly used as a secondary test, and parent advocacy is a large component of newborn screening. Disorders are added to newborn screening after a disorder has been nominated. There has to be evidence to support why that disorder should be included on newborn screening. Why that disorder should be included on newborn screening. There's an advisory panel that looks at those disorders. The panel votes, and then the Secretary of Health and Human Services signs off on that. More recently, however, HHS eliminated this advisory committee on newborn screening, so how rare disorders will be added to newborn screening in the future is a little up in the air. Much of the funding to study new disorders also came from state, federal, and especially CDC support, and that is also up in the air at this point. A number of years ago, when the whole genome was sequenced, many people thought that whole genome sequencing would become the standard of care for many medical environments, including newborn screening. And this is a quote by Francis Collins, who predicted that 5 or 10 years post 2012, that's what the world would look like. We're a little delayed in that, but as I'll show you later on, we may be getting closer soon. So the questions in thinking about genomic screening, and in particular genomic screening for cancer risk, are which genes should we do? What should be the level of evidence for benefit of early detection? Do we need randomized trials showing the benefit of each gene or even each variant? That seems somewhat infeasible. What should be the penetrance of deleterious variants? Does it need to be known? What's the impact of a genetic diagnosis on a family? What's the burden, both psychological, economic, health burden, and the benefit, family planning, cascade testing, the individual benefit to the child? What's the impact on the healthcare system in terms of capacity for care and costs? And what are the issues around consent, privacy, and ethics? There are some classic criteria for newborn screening that have been adapted over the years, but were first proposed by Wilson and Younger. They're known as the Wilson and Younger criteria. And they state that newborn screening should include, or screening in general, should only be done for important conditions for which there's acceptable treatment, for which there are facilities for diagnosis and treatment, that it's difficult to recognize otherwise, and that for which there's a suitable screening test, that the natural history is known, and that it's cost-effective to diagnose and treat. For those of you who are oncologists in the audience and think about this, in fact, newborn genetic screening for cancer risk probably meets many of these criteria. We have compelling data available that about 10% of pediatric cancer patients have a germline mutation. We have very well established surveillance recommendations that many of my colleagues participated in to develop for patients who have had a germline variant detected. And early detection of malignancy may lead to improved survival. This has been established in some conditions and impaired in others. So if we wanted to study this, the question is, how would we do that? So what about population-based newborn screening for cancer risk in the United States? What are the potential clinical benefits, consequences associated with genomic sequencing for a panel of genes or for genes associated with cancer risk in terms of outcome for early onset malignancy? Well, this would be very hard to study prospectively, but I've had over the years a very productive collaboration with a colleague of mine, Jennifer Ye, who's a decision scientist, where we've been able to develop simulation models. Those models that we focused on have often been in my other area of interest, which is survivorship, projecting out into the future what a survivor population might look like based upon their exposures and their initial cancer history, as well as behaviors, for example. In this particular model, we took a sort of a different approach to kind of create a hypothetical birth cohort and then apply universal newborn genetic screening for a limited set of autosomal dominant cancer predisposition syndromes. And to do that, we developed this cohort, 3.7 million babies. That's about the number of babies that are born in the United States a year. We applied SEER data, ClinVar data, NOMAD data, cost data from CMS, and a literature review to look at prevalence data and penetrance data, and applied a panel test of a panel of 11 cancer predisposition genes that were selected for their association with very early onset solid tumors and brain malignancies, for which surveillance might be recommended in a newborn who was found to carry a variant in one of those genes. And then we studied the hypothetical outcome, meaning the development of a pediatric solid or brain cancer in this hypothetical birth cohort in those patients or those hypothetical individuals who underwent screening, comparing that to a hypothetical population that didn't undergo screening, and looked at the outcome and the cost. The results of the model suggest that newborn screening for cancer risk with these 11 genes would decrease overall cancer deaths before age 20 by 8%. This would be due to a decrease in cancer deaths among those with a cancer predisposition syndrome by over half. And that would be by early detection, stage shift, and better outcomes. And that would also increase the number of adults alive at 45 years of age, and a significant reduction in adults, survivors who are at risk for adult onset cancers because of radiation-associated late mortality. The cost effectiveness in this analysis was largely driven by sequencing costs because of the obviously small number out of that 3.7 million that are detected to have germline variants. So this was suggestive that our panel, at least, might be reasonable to apply to a population. Again, doing that prospectively becomes very difficult. So we decided to then go about this retrospectively and study genomic newborn screening for cancer risk using an already collected set of newborn dry blood spots. And I will talk with you about this study at some length. What we did is we took advantage of the linkage between the Michigan Neonatal Biobank and the Michigan Cancer Registry. I neglected to mention my colleague, Richard Parad, is a neonatologist and in charge of newborn screening for the Brigham and Women's Hospital and an expert in newborn screening. This was funded by the Bridge Foundation, which funds collaborative research at the Dana-Farber Harvard Cancer Center, and was done in collaboration with the state of Michigan's BioTrust for Health. So we took advantage of the linkage between Michigan's Neonatal Biobank and the Michigan Cancer Registry to identify those infants born in Michigan between 1987 and 2020 who developed a solid or brain malignancy, excluding germ cell tumors and skin cancers, and who developed those tumors at age less than or equal to 8 years. We focused, as I said, on solid or brain malignancies because those are very clearly associated in germline carriers associated with described and accepted surveillance recommendations. We excluded germ cell tumors and skin cancers. Germ cell tumors have not been, for the most part, associated with germline variants. It was also very hard to distinguish benign from malignant germ cell tumors in this age range. And then we excluded skin cancers. We decided to only go to 8 years of age in the spirit of why we do newborn screening. If we were looking for germline predisposition to cancers that occur later in life, during late childhood or adolescence, it would make perfect sense to do that screening. It might make perfect sense to do that screening, but not in the newborn period. From Michigan, we received birth and cancer registry data, including demographics, diagnostic information, stage information, and cancer outcomes. We did a laboratory analysis by isolating DNA from a 3.2 millimeter dry blood spot punch from the Michigan Biobank. And this underwent standard DNA library preparation and targeted next-gen sequencing for the 11 genes. I'll give you the list of genes again fairly soon in case you don't remember. We then classified the variants using an AI-supported variant classification application provided by Fabric Genomics. These then underwent manual interpretation using the American College of Medical Genetics criteria and identified carriers of pathogenic or likely pathogenic variants. This allowed us to calculate the prevalence of pathogenic or likely pathogenic variants overall and by diagnosis, and then did some statistical analyses to understand the relationship between some of the genetic findings and clinical findings. So here was our cohort. We identified 1,948 infants or dried blood spots from infants. Each of these infants developed a childhood cancer on or before their 8th birthday. The median age at diagnosis was 35 months. About half the patients had localized disease, but 40% had metastatic or regional disease at diagnosis. About half received chemotherapy, about 20% received radiation, and 20% died of their disease. One of the unique features of this cohort is that it's unselected. It's a population-based cohort of children with cancer. I'll now go into the results of this study. Almost all of the samples yielded adequate DNA and sequencing coverage for inclusion in our analysis. So we were at first worried that that tiny little dried blood spot would not be enough to get our analysis done, but in fact, the DNA extraction and the library preparation were adequate. We detected 132 pathogenic or likely pathogenic variants, or put another way, 6.8% of the overall cancer cohort of children with solid or brain tumors before the age of 8 were diagnosed as having a cancer predisposition syndrome. 115 of these 132 were sequence variants, and 17 were large deletions. The number of variants detected are shown in the bar graph on the right, showing the genes across the bottom and the number of variants on the y-axis. RB1 and TP53 were the genes with the largest numbers of pathogenic or likely pathogenic variants. And there were less than 10 variants detected in each of the other 10 genes. Should be 9 genes, essentially, and then no pathogenic or likely pathogenic variants in ALK were detected. So that ALK won't be included in this. So based on the size of the Michigan birth cohort, we estimate that newborn screening with this panel would have identified the 1 in 27,000 infants who have germline variants in one of these genes and an early onset cancer. This is well in keeping in terms of frequency with what one might expect in a newborn screening setting. And you can see there on the bottom left of the slide the prevalence in newborn screening of some of the diseases standardly included in newborn screening. The diagnosis distribution of the overall cohort, which I showed you earlier, is shown on the left. On the right, you can see the diagnostic distribution of those with germline variants, showing a heavy prevalence or over-selection of children with retinoblastoma, the presence of those with sarcoma, and of brain tumors. Of note, there was excellent concordance between our genetic findings and cancer diagnoses. As you can see here, the RB1 variants that we saw were almost exclusively in children with retinoblastoma, with only one individual without retinoblastoma who turned out to have pineoblastoma. The diagnoses that were found, that were seen for each of the genes, were really those that we would have expected, with 100% of the WT1 carriers being associated with renal tumors, with Wilms tumors. And then interestingly, there were 6 cases of medullary thyroid carcinoma in the cohort, and in all 6, there were pathogenic or likely pathogenic variants detected in the RET gene, and no other mutations found in those with medullary thyroid carcinoma as examples. If we look by diagnosis, and let me talk you through this slide a little bit, on the y-axis is the percent of the total individuals with a specific diagnosis for whom a germline variant was found. The colors are color-coded for which gene was involved, and the numbers on the bottom in the y-axis are showing you the number of cases within this cohort. So of note, even though this is a population-based cohort and we have a relatively high number of individuals, some of the diagnoses remain quite rare. Not shown here are the 100% of kids who developed medullary thyroid carcinoma who had RET variants, and there are a number of rare diagnoses with no detected variants. However, among the brain tumor patients, you can see that there's a preponderance of TP53 mutations in those with choroid plexus carcinoma. The 1 in 6 kid, the one child with pineoblastoma and retinoblastoma, an RB1 mutation, or 1 in 6 of the pineoblastomas with an RB1 mutation, about 12% of medulloblastomas associated with a germline mutation, and then a small percentage overall of the large number of brain tumors in the cohort. Here are our sarcomas, again seeing P53 as a large contributor. The contribution of the PATCH1 mutation in rhabdomyosarcoma and of Dicer in sarcomas overall are also visible. And then the rest of the tumors among retinoblastoma patients, approximately 40% had germline variants, 80% of the known bilaterals, and 23% of those with unilateral or those without laterality known. The remaining cases had as I mentioned, had the expected germline variants that we might have been predicted to find, including adrenal cortical carcinoma and the association with TP53 mutations, the association between lung and pleural tumors and Dicer mutations, and the association of the APC variants in hepatoblastoma, for example. There were 7 diagnoses with greater than 10% of the children who developed cancer by age 8 with germline variants, including medullary thyroid, retinoblastoma, choroid plexus carcinoma, pineoblastoma, medulloblastoma, adrenal cortical carcinoma, and pleural pulmonary blastoma. What about outcomes in this cohort? What we would have loved to have been able to do is understand whether having a germline diagnosis led to cancer screening, which led to early detection, which led to improved outcomes. But of course, as a retrospective study, we cannot tell that in this cohort. But importantly, we needed to look a little bit more deeply into some of the clinical features. Put another way is, if you did newborn screening and all variant detected infants were diagnosed with low stage disease, didn't require intensive therapy, and did well, then there wouldn't be a need to pursue newborn screening. So we wanted to at least pull out from the clinical data a sense of whether newborn screening could in fact make a difference. For RB1 and retinoblastoma cases, as I mentioned, we detected 80% of dry blood spots from infants who developed bilateral retinoblastoma had RB1 variants, and 23% of dry blood spots from the rest of the cohort had RB1 variants. The children, as might be expected, who developed retinoblastoma in the setting of an RB1 variant were diagnosed at a younger age, which has been described clinically. And there were no differences between cases and with and without pathogenic or likely pathogenic variants in terms of stage, meaning local, regional, or metastatic, therapy type, survival, or second cancer, suggesting at least that there's room for improvement. And we unfortunately have no information about visual outcomes, which I think those of us who care for retinoblastoma patients have the sense that, and the literature supports that, the biggest impact of knowing that a child has an RB1 variant at birth is preserving vision and avoiding radiation. How about Lee-Fraumeni syndrome? Here's a pie chart on the left showing the diagnoses associated with germline pathogenic or likely pathogenic TP53 variants. And when we look at the survival of the TP53 carriers versus those who are found not to be carriers, excluding all the retinoblastoma cases in this analysis, we find the survival of the TP53 carriers to be far inferior. Now, of course, this may be an association with the biology of their tumors and of not of early detection or other ways in which we might use newborn screening to improve these outcomes, but it certainly gives a sense of room for improvement. And then finally, among those with brain tumor predisposition, syndromes, the pie chart on the left takes all our brain tumor cases and divides them up by all our brain tumor cases who had germline variants detected. There were 27 of those, and shows you which genes were involved in those cases. There was, again, a younger age at diagnosis in carriers versus non-carriers. There was no distribution, no difference in stage distribution or first therapy type, but survival, again, was worse in the germline carriers. Again, an opportunity for improvement in outcome, perhaps avoidance of radiation therapy as well. The overall limitations on this study, as I mentioned, are many. We have no information on any of these cases on whether the risk was clinically known, although it spans many decades in which that risk was unlikely to have been known in the 80s, 90s, and early aughts. A larger gene panel, not just these 11 genes, might identify a larger portion of genetically predisposed children. We don't know if early detection will improve outcomes. And most importantly, we didn't study non-cancer cases. How many babies, if we did this kind of screening, how many babies would be diagnosed with a cancer predisposition syndrome and not develop cancer? And what's the harm associated with this? That is a question of our research group as we go forward. One of the studies looking at this is called the UROC study, which stands for Understanding Risk of Cancer in Kids, being performed by Kayla Hamilton, who's a genetic counselor, and many others in our group here, and supported by the Survey and Data Management Core at the Dana-Farber Harvard Cancer Center. The study involved qualitative interviews of parents whose children have a known cancer predisposition syndrome. The syndromes of the 28 parents who participated, the children of the 28 parents who participated are shown in the bottom right. The parents were interviewed, they provided demographic information and did a test of their genetic knowledge. What we really wanted to understand is what's the burden on you as a parent and on your child of knowing that your child is at risk without having developed cancer. So these are all individuals whose child has not yet, and we hope won't, develop cancer, but are known to be at risk. In the genetic knowledge test, we used a scale called the no-gene scale, which asks parents to answer some questions about what they knew about cancer risk. And in these highly engaged parents, it was clear that their understanding of cancer risk was actually quite good. You can see that nearly 100% of the parents answered the questions correctly. However, the understanding of inheritance pattern, penetrance, and cancer patterns in the families were faulty or absent in up to 20% of the families. For example, about 10% thought that cancer will definitely develop. There was a lack of understanding about what the inheritance pattern would be thinking that all children inherit a mutation rather than in most cases in this cohort, 50% risk, and whether or not cancers develop at a younger age or not. So we have a lot to learn about how to teach our parents of carriers. And then we really sought to understand the emotional impact of being a family in which a genetic risk marker has been identified through the process of genetic testing, adjusting to the diagnosis, choosing surveillance, receiving surveillance, perceptions of the child's health, and outcome of surveillance. And we did that through qualitative interviewing, which tried to characterize the emotional impact of each one of these steps for a family. And we found a variety of findings that both are encouraging and concerning as we move forward with genetic risk testing in newborns. One of the parents said, we had to get him testing so we can stay on top of him and do what needs to be done for his health. The family experience definitely weighed in here, which would be different in population-based testing. My dad had it, I had it, so I knew what it meant. It was easy to decide to get tested. And then here's a parent who said the results were really depressing. I remember getting a feeling of doom. Parents were able to cite the benefits, being comfortable with false positives. They felt that the testing was empowering and surveillance was empowering. But surveillance had its downsides, blood work, ultrasounds, the children acting out because of having to go through testing, having it being somewhat hard to deal with. One of the parents said it was awful. There's cancer worry involved. It's really hard whenever they say something like, my leg hurts, or I have a headache. It's a different level of concern for their child who's a carrier. And then the positive when a tumor is detected is we were really glad that it occurred when we picked it up when it was really small and it was treatable and it didn't need chemo or radiation. So as I personally think about bringing this forward to population-based testing, I think about a large number of parents who will be dealing with a cancer risk diagnosis and going through these cycles and thinking about how we have to have the right support for these families going forward. As mentioned, we recently received a Crazy 8 Initiative grant to really look at prospective population-based testing, getting us ready to scale up for this testing, to try to understand the prevalence of variants in a large non-cancer cohort. As I mentioned, we didn't study children who didn't develop cancer, but we'll be doing that in the Crazy 8 Initiative. Understanding the impact on families, really figuring out how to communicate these information to the families, and understanding the preference of pediatricians and parents regarding focus versus broad testing for cancer risk. I'll go through our study a little bit. Here's our team. It's a multi-institutional study, largely between Texas, investigators in Texas at Texas Children's and Baylor College of Medicine, and here in Boston, as well as engaging an advocate group called Expecting Health with expertise in communication around newborn testing. We want to be able to roll out newborn screening in a way that is cost sensitive, and we think we can do that reducing the cost through pool testing. So instead of, this is a complicated slide, but it shows you that when you conventionally are trying to test individuals for a genetic finding, you're basically making 100 libraries, 100 unique barcoded DNA libraries, and each sample is tested for the presence or absence of a germline variant. However, these are rare enough that you could conceivably create a pool of variants and reach like 10 samples per pool, each pool with a unique barcode. And then any individual pool that comes up with a abnormal variant can be disambiguated to the per sample level. So we're working on that in our study to really be able to scale up and do thousands of specimens prospectively. And that is shown here. So we will get dry blood spot punches, we'll do pool DNA analysis, sort of 10 sample barcoded libraries, sequencing, and then variant interpretation. And as I said, this pipeline is designed to be able to keep the screening for cancer risk genes within the cost that is generally used for newborn screening. We're also trying to figure out how to educate parents in our case, because this is a study, how to get consent, but how that might be rolled out in a population basis. This will be done through focus groups and community input to generate teaching materials. And then we'll be developing our intervention both in the prenatal and postpartum setting in order to decide when this information should be shared with families as a possible test for their children. And then which genes? This will be a randomized trial where we're going to focus either on two very specific, somewhat easy to describe to parents conditions, early onset Wilms tumor and retinoblastoma, and give the parents the option to participate or not participate in testing for those two genes, versus a sort of larger cancer panel that includes those two genes. And we'll be studying whether the uptake for the limited panel versus the larger panel is different. We want to understand the parent experience as well as the pediatrician experience, and we want to understand any potential harm, including misunderstanding or cancer anxiety. And this randomized trial will be conducted in Texas and in Boston, in order to really get an experience of how newborn screening for cancer risk might be rolled out with some sensitivity to the varying experiences of different racial and ethnic groups in our communities. So meanwhile, I'll just wrap up with telling you about some other people's work. Whole genome sequencing is being explored for newborn screening. The Beacon study is a recently funded study. It's funded in the past couple of months. And it's a United States project for newborn to look at genomic newborn screening, whole genome screening and sequencing in about 30,000 babies. To be done in about 30,000 babies. This will be conducted in Boston, Texas, New York, or the collaborators are from Boston, Texas, and New York, and it'll be rolled out in a number of state labs, somewhere between, I think, 7 and 10. The sequencing will be done by GeneDx, and there's a focus on disclosure for about 500 conditions. The conditions are being chosen based upon actionability, and actionability includes the possibility of inducing or inviting surveillance for disease in the first year of life. So it would include some of the cancer risk genes. And Sharon Plon, my colleague from the Crazy 8 initiative, and I have been involved in helping determine which cancer risk genes should be included in this effort. One of the things that my group has done recently is to look at the ongoing whole genome sequencing studies that are being done worldwide to see whether or not there is a consensus about which cancer risk genes are being or should be included. And interestingly, there really is no consensus. We were able to get the gene lists. When people do whole genome sequencing in newborns, they don't share every gene. They predetermine which genes results they're going to share, and they compile what's known as a gene list. We were able to look at the gene list for 21 ongoing or completed genomic newborn screening studies and found that there's really no consensus on which genes to include for disclosure. The median number of genes included is 3, but there's a very wide range from 2 to 31. There's a lack of consensus around whether adult cancer predisposition genes should be included, like BRCA1, for example, some of the Lynch syndrome genes. And even RB1, only 16 out of the 21 ongoing or completed studies included RB1. However, I'll wrap up with this story. I recently went to a genomic newborn screening meeting. And at that meeting, there was a lot of excitement about RB1 in particular, with a whole session almost devoted to RB1. Part of the reason was that the Generation study, which is the genomics study, newborn screening study in England, is doing sequencing of a planned 100,000 newborns to look for about 200 conditions. And they identified a baby with an RB1 mutation who was found to have retinoblastoma and is undergoing treatment after an earlier than a clinical diagnosis would have permitted. So there's sort of an excitement about newborn screening for genetic risk for retinoblastoma, which sort of brings me full circle in my career to what I've been thinking about. So in conclusion, newborn screening is expanding the number of diseases that can be identified in newborns, and newborns and their family members who are at risk for certain malignancies are likely to be identified in the future as newborn screening expands. As pediatric oncologists, this gives us an opportunity for thinking about studying surveillance more deeply in these individuals, thinking about novel methods of surveillance, including perhaps ctDNA or understanding other genomic or other modulators of risk, and in particular about prevention. Would this be an opportunity to roll out some ideas about prevention going forward? And I think with that, I'll wrap up and say thank you, invite any questions, and in particular, thank my colleagues who have been on this journey with me, in particular, Richard Parad, who's my colleague in newborn medicine, the collaborators in Michigan who have been so helpful in getting us those samples, and my many collaborators across the country who are working on this with me as we go forward. So thank you very much.
Okay, thank you, Dr. Diller. That was an amazing presentation, and we have quite a few questions in both the Q&A and the chat areas, so I'll start reading some of those off to you. And everyone on the call, feel free to continue to ask questions as we go through this Q&A session. So our first question is, in the case of the sister with the RB1 mutation who was treated with local therapy only, are you nervous about her kids, or her and her kids like her, developing pineoblastoma if they don't see systemic chemo?
Oh, that's an interesting question. I think the person asking the question is wondering whether systemic chemotherapy will prevent the development of pineoblastoma. And there's been some suggestion that as we've used systemic chemotherapy in kids with bilateral retinoblastoma, we've seen less pineoblastoma. Certainly, I wouldn't use chemotherapy as prevention, but it's definitely something we should keep our eye on. If we use less chemotherapy, will we see more pineoblastoma? A really reasonable thing to think about as we go forward.
Great, thank you. Another question is, had the RB1 PVs detected in the babies with RB already been picked up by standard clinical pathways? Parentheses, the Michigan study.
Can you ask that again? Are you the likely pathogenic variants in RB1?
Yes, have they been detected in the babies with RB already? Have they been detected in the babies with RB? Have they already been picked up by standard clinical pathways?
I'm not 100% sure. I understand the question. The cohort from Michigan was retrospectively identified as having developed the disease. So they were picked up not genetically, but clinically. I have no knowledge of whether clinical germline testing was performed in any of the 1,948 kids that we studied. That was not data that was available to us, whether or not because of family history or because of bilateral disease that someone did clinical testing. We are unable to assess that.
Okay, thank you. Another question is it possible or worthwhile to screen for blood cancers? TP53 is seen sometimes, but are others potentially detectable at birth?
That's a really great question. When I started this study, I really was hesitant to include cancer predisposition genes associated with leukemia development because of some data that says that you can actually find evidence of the leukemias in the newborn dry blood spots. So I thought it would be hard to tell the actual somatic disease versus germline. And because I'm a solid tumor doctor and interested in solid tumor detection, embryonal tumors in very young children, I sort of focused on my area of interest. That being said, I think the field of germline predisposition to leukemic disorders and it has expanded over the years that I've been doing this, and I can imagine that in the future, testing for either the presence of the somatic presence of a childhood leukemia or a predisposition to a childhood leukemia might play a part in newborn screening. The interesting thing is that we don't really know. There's some data from Mel Greaves from many years ago that the sort of leukemic clones, I put that in quotes because I don't know that they all are associated with leukemia. Some of them disappear over time and the child never develops clinical leukemia. So it's a little fraught. The other thing about leukemia is the role of early detection is not entirely clear. In other words, detecting a leukemia a month earlier than when it presents clinically is probably not impactful on outcome.
Thank you. Another question is, in the Michigan cohort, do you know how many of those patients were identified to have predisposition before diagnosis of their tumor? One might expect some of the patients with RB, TP53, and RET may have been identified just based on family history.
It is entirely possible, and no, I don't know.
Okay. An additional question is, was a pedioblastoma in a trilateral retinoblastoma?
No, it was a separate kid.
Or-
Interesting, right? That child did not have retinoblastoma. I'm going to go back to that other question about knowing whether the child had the disease or not. You know, it's interesting. So when you get cancer registry data, you don't get the results of a child who has their a risk for medullary thyroid carcinoma, who has their thyroid removed as a preventive measure if they don't actually have medullary thyroid carcinoma. So the 6 cases of the RET carriers all had clinical medullary thyroid carcinoma, which makes me a little suspicious that they were not known. There must be other kids in the state of Michigan who have had their thyroids removed because of an underlying risk, but we did not have that access to that data because they wouldn't be in the cancer registry.
Okay. An additional question. They preface this by saying it may be a little bit controversial, but they're asking, should we broaden the panel of genes to include adult cancer risk genes, such as CHEK2, to define the clinical phenotype of those genes in children? We don't know what that looks like, but we are seeing evidence of some pediatric disposition, and the benefit is defining the phenotype. So is the risk identifying, the risk is identifying risk, but knowing what to do with it?
Yeah. I think I took a sort of as a clinician, I took a sort of a priori clinical approach to the studies and the sort of advocacy that I'm doing, if you will, picking at those genes that we know or we have a strong suspicion it would make a difference to know early. I think you're absolutely right. We have a lot to learn about which genes should be included, what the modulators of risk are, even in the genes that we know about, and that as our knowledge expands, what genes are included, I'm sure will expand. I do have some concerns about including adult onset diseases, mostly from an ethics perspective. You're sort of using the child as a marker for family risk. Some people in the newborn screening world think about that as if you find something in a child that's life-saving for the mother, let's say, then you've done good for the family. That's one end of the spectrum. And then the other end is, a mother could always get tested, and the individual baby has their own personhood and rights to their own test and shouldn't be a marker for their mother's test. So there's a lot of controversy in that going forward.